We can start.
Yeah, thanks. Thank you very much, Mr. Vinay. And on behalf of the 9th annual conference of
Just a minute.
Heart
Just a
Failure.
minute. Just a minute.
Yeah.
Rohit, we can. Are we live? Can we start? Just a minute, sir. We're just going live on the platform.
Sure,
I'll
sure, 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 sure.
We can start. Satish.
Okay. All right. Good evening to all doctors. On As a part of the live virtual webinar in this 9th annual conference of Heart Failure Association of India, it's my pleasure on behalf of Microlabs to have the session today evening, which has been titled Neprilysin Inhibition in Heart Failure, a deep dive. I believe this is a topic which is quite relevant in current context and surely would have a lot of things to be discussed. Uh, for the same, it's my pleasure also to have with us a very, very eminent international, national KOL amongst us who will take us through this evening for the next 45 minutes and enlighten us on this topic very aptly. To briefly introduce our faculty for today evening, a very well-known national KOL, Dr. Tiny Nair, who is the head department of cardiology at the PRS hospital. And to his credentials, he has many, many awards. The Best Doctor Award, Government of Kerala in 2006. The Most Inspiring Doctor of India, Economic Times Award 2019. The Best Reviewer, Annals of Internal Medicine 2019, 2021. He is on the editorial board of the Hypertension Journal, the Indian Heart Journal, the Kerala Heart Journal, the European Journal of Heart Failure, and is a member of Hypertension Council of CSI. To his credentials, he also has numerous papers presented globally in various international meetings. And I'm sure this topic, what he's going to share with us today, would surely be a deep dive in a new enlightening of how this segment and this molecule in heart failure can surely be a big boon for the Indian patients. With this, I would request Dr. Tiny Nair to take us through this evening. Over to you, sir.
Thank you, Satish, for that nice introduction. Give me a moment by the time I share my slides. Yeah, am I visible and audible?
Yeah, you're audible, sir.
Right. Thank you. Thank you. So, our topic today is RNA, neprilysin inhibition. Well, we have been using RNA, sacubitril valsartan for the past about 5 years or so. So this would be a deep dive into what do we do in the background that it is now freely available in the Indian market. 11th of September, 2001, something unforgettable happened, right? So September 9, 2001, morning at 8:45, the first jet, American Airlines Flight 11, hit the North Towers. And exactly 11 minutes later, on September 9th morning, the second airline jet, United Airlines 175, hit the South Towers. And within about half an hour, the 110-storied towers were reduced to rubble. But we're not talking about that. The point is, this particular episode changed the entire geopolitical scenario of the whole world. It was a game-changing event, right? Surprisingly, on the same date, September 11, 2014, exactly 13 years later, on the same date, on that same very date, came out a trial which would subsequently change the entire path, the way we treat congestive heart failure, right? Yes, we are talking about the Paradigm HF trial. We know today everything about Paradigm HF. 8,000 patients, 1,043 centers, 47 countries, heart failure with an LV ejection fraction of 40%. They were the patients who were taken out. 8,442 patients, right? And what did we find? We all know what we found. We all very clearly know what we found. We found that at the end, compared to the standard therapy for heart failure, along with enalapril, when ACE inhibitor enalapril was substituted by RNA, sacubitril valsartan, we had a very clear 20% reduction of event rate, right? Of what event rate? The primary event rate, which consisted of cardiovascular death and heart failure hospitalization. So RNA, sacubitril valsartan, given in the background of a properly well-treated heart failure with ejection fraction less than 40, reduced primary endpoint in heart failure of cardiovascular death and hospitalization by relative risk of 20%, right? Not just that, if you look into the secondary outcomes, heart failure hospitalization, just the hospitalization, was reduced by 21%. Cardiovascular death, 20%. Total mortality, 16%. So it was truly a fascinating data to start with, right? Now, with that background, let us look at the Indian scenario. This is the Trivandrum Heart Failure Registry. We were there, a lot of our friends were there. The entire program was spearheaded, conceptualized, and taken forward by Dr. Harikrishnan from Sri Chitra. Now, these were patients of heart failure in Trivandrum, right? And the data of this 1,200 patients, we got published in American Heart Journal, and subsequently in the next 5 years, from 2015 till 2022, we got it published in multiple journals, multiple leading journals. We learned a lot of data, right? But one of them was this. The latest publication shows that the 5-year mortality, keep in mind, 5-year mortality stood at 50%. So 5-year mortality of our heart failure patients intravascular amounts to 50%. Right. Now, how did we treat them? Well, if you look at that in this graph, on the x-axis, you have follow-up times. You see the dates, right? 20, 40, 60, 100 days. And on the y-axis, you have the cumulative mortality. Now, you see, when this patient were treated well, guideline-directed medical therapy, their outcome was good. The bottom red graph. But when they were not treated according to guideline-directed medical therapy at discharge, their results were bad. They had 3 times higher event rate. And what event we are talking about? Cumulative mortality. So which means our discharge medication at hospital discharge decided their long-term outcome. Whether they are going to have 3 times higher death rate at 100 days or not. What was painful to see, what was really painful to see is this. 25% of our patients, 24 to be perfect, received guideline-directed medical therapy, while 76% of our patients didn't. And we in Kerala boast ourselves of practicing evidence-based medicine, right? But 76% of our patients did not get evidence-based treatment at discharge for heart failure. And what is this evidence-based medicine? Not ARNI, not SGLT inhibitors, but just 3: ACE inhibitors, beta blockers, aldosterone antagonists. So you see, there's a huge lot of difference between what we are talking about and what we see in real life, right? Now, see, we were talking about the 5-year death rate, right? 50%. Okay. And let us say we are looking at this data. This is very interesting. That came out, again, the same group of Dr. John McMurray, who published in JACC 5 years after Paradigm HF. So let us move forward 5 years. What did we find at 5 years once we move forward from Paradigm HF? Okay, look at that. If you analyze the survival at the age 65, so let us presume somebody at age 65 has an heart failure and started on standard drugs with sacubitril valsartan. And let us theoretically say we are comparing it with giving enalapril instead of sacubitril valsartan, right? As we see in the graph, sacubitril valsartan did better. How much better? We are talking about survival, right? How much better? We see that sacubitril valsartan pushed up his survival total to 11.4 years. And the mean difference between the control group was 1.3 years. Survival improved by substituting sacubitril valsartan from enalapril, improved by 1.3 years, right? Look at freedom from primary endpoint, which means he is alive and he is out of hospital. Not just that he is fine, he never needed to come back to the ER with an acute pulmonary edema, right? So freedom from primary endpoint. If you see that, even better data, sacubitril valsartan pushed up that to 9.2 years, and the difference was 1.6 years time. So our decision whether or not to put the patient at discharge on sacubitril valsartan tends to make a huge difference in the long-term outcome. Now, if we look into the general about all-cause mortality in heart failure and try to see as to what drugs clearly improve mortality, all the drugs are there. Let's put a straight line at 1, which means anything on to the left, there is benefit in survival. We see clearly we have ACE inhibitor, we have beta blockers, we have MRA, we have ARNI and SGLT inhibitors, which clearly improve survival. That's the reason why we say today that you have to give the standard 4 drugs. So you would say, okay, we have ACE and ARNI here. Between these two, between the ACE on top and ARNI on bottom, see the ARNI looks better, but how much better is it? And if you try to look at the number needed to treat, it is fascinating that if you change that ACE to ARNI, all you need is to treat 21 patients to improve one survival or avoid one death. So think of it, right? You'd be seeing in an OPD, how many patients daily? 50 patients, right? And of them, I'm sure about 8 to 10 would have some kind of left ventricular dysfunction, which fits in with the definition of cardiac failure. And these patients, you need 21 patients to be treated by ARNI instead of ACE inhibitor to get the benefit of one extra survival. I think that is certainly truly fascinating. Now, if you look at the standard, the guideline and the logo of the ESC, it says heart failure drug treatment, the fantastic four. What are those fantastic four? Beta blocker, SGL inhibitor, ARNI, and MRN. That's why you see ARNI is, I've highlighted in red because ARNI is special. Now here there is something that we need to understand. This is something that everyone knows, that in heart failure, we have acceleration of sympathetic nervous system. We have RAS activation. We have, today we know, we also have a neprilysin activation, right? But what we don't realize is this. Yes, we know that sympathetic nervous system activation is neutralized by beta blockers. RAS by ACE or ARB. Neprilysin by sacubitril. So that is why when we combine sacubitril with valsartan, we get a dual pathway inhibition of RAS and neprilysin. So when we talk about neprilysin inhibition, people think, yes, it is an addition of neprilysin inhibition. But stop there. It is much beyond that. And that is what we need to realize today. When we say talk about valsartan, okay, it inhibits angiotensin II receptor level, right? So we know the benefits and problems of angiotensin II. It's a vasoconstrictor. Through aldosterone, it retains salt and fluid, creates hypertension, worsens heart failure, right? But when we are talking about, for example, sacubitril, it is much more proximal. I mean, this is very interesting. So when you are inhibiting neprilysin, it is far more proximal. So not just that it inhibits neprilysin, it inhibits a huge set of vasoactive peptides, right? Look at that. So when we use sacubitril, we not only inhibit neprilysins, but inhibit bradykinin, BK, substance P, NP is neprilysin, ADM is adrenomedullin, apelin, a huge lot of vasoactive peptides. And that's why we get effects far beyond simple inhibition of neprilysin. So today, when we talk about combining a neprilysin inhibitor like sacubitril to an ARB like valsartan, we get a huge change of the metabolic hormonal sympathetic milieu in heart failure. Certain things that go beyond our present knowledge. But see, we are all clinicians, right? You and me, we are all going to see tomorrow morning a host of patients, and many of them would be heart failure. So there are a huge amount of challenges that comes in the treatment of heart failure in the background of using neprilysin inhibitor. And let us go into that one by one, right? The first is ARNI sequential or simultaneous. This is what we talk about in every meeting. I think this needs to be discussed and how to titrate. Yeah, that is very important. What are the tips and tricks from the experts? Look at that. Now, if we look into Javed Butler's beautiful article, if you're not read, please go through it and read. It's an old one, 2019, but worth reading, where he talks about the clinical course of HFrEF. And if you look at the clinical course of HFrEF in their series, you see something unusual. You see, when we look at the events, both death and rehospitalization after diagnosis and hospital discharge, we see that about 55%, look at that bar, of the events occur in the first 30 days post-index. So your patient comes acutely dyspneic, you treat, He becomes better. He says, sir, thank you, I'm going home. He looks fine. Understand that in this so-called patient is looking fine, most of his events are going to come in the next 30 to 45 days. Okay, so if we have missed the bus, we have not started him on what proper treatment he deserves, he is going to get into problem, right? So start treatment in hospital. But the question is that feasible, right? So the question is that feasible? So what are we talking about? We are talking about, we have the hospital discharge at that red arrow, right? So can we start all these 4 drugs, ARNI, beta blockers, MR, and SGLT inhibitors, just prior to discharge so that we can give him the best possible outcome? Yeah, certainly we can, right? Not that it is possible, not patients, but we should try to do that, because even if in 20% patients we are successful in doing that, we are doing a big service to the patient, right? Today we have enough data, for example, the transition data, the pioneer heart failure data, which clearly tells us that yes, it is feasible and possible to safely start and uptitrate ARNI in hospital. Right. And that is the reason why, if you look at the data, the viewpoint that came in JAMA, this is a slide that we so often show in our meetings, that if we are talking about therapy, look at that. Day 1, initiate all 4 drugs, like ARNI, beta blockade, MR, and SGLT after admission. By day 1, we don't mean day 1. We mean the first day after the patient is stabilized, patient is off inotropes, of vasodilators, and not on escalation of diuretic dosage. Right. Now, so simultaneous or rapid sequence, if you look into that, the whole concept is that by day 1, your patient is started on medications, continues and uptitrated, so that by about 3 weeks' time, he is on full dosage of all 4, ARNI, beta blocker, MRA, and SGLT inhibitors. Right. So the point is, delaying initiation increases preventable deaths. In fact, today we are at a point where we have fantastic drugs. So the main reason for increase in mortality in heart failure is physician inertia, right? We would start and no, patient won't tolerate hyperkalemia, hypotension. We'll take that all up one by one. Now the point is, when we are talking about day 1, again we repeat, we are not meaning day 1. We are meaning that the patient should be off inotropes for 24 hours, off vasodilators for at least 6 hours, no dose escalation of IV diuretics for 6 hours, and a systolic blood pressure of at least more than 100. So let us repeat, patient is off inotropes, off vasodilators, no dose escalation of IV diuretics is needed, he is fine, systolic blood pressure is 100, we should have the green signal to start ARNI, right? Now, the main challenge, obviously, that brings us to the topic is hypotension. Yeah, we know that ARNIs cause hypotension more than ACE inhibitors because they're more potent, right? They are more potent vasodilators. So if you look at the data of Paradigm, for example, here if you see the golden bar is ARNI, sacubitril valsartan, and the gray bar is enalapril. Look at that. In Paradigm, certainly there was more symptomatic hypotension, right? 14% in sacubitril valsartan, 9% in enalapril. In fact, if you take symptomatic blood pressure less than 90, obviously more with sacubitril valsartan, right? Because it is more potent. So you are likely to get more episodes of hypotension when you start patients on ARNI, no doubt about it. But if you are looking at discontinuation of therapy in the same trial resulting from hypotension, so hypotension, you have to totally stop and you could never go back. That was no difference, 0.9 and 0.7. P-value not significant, but this is a trial background, not real life, right? So they were monitoring the patient. But the point is, hypotensions would be certainly more, but that does not mean that you need to back out and never restart. So hypotension needs to be carefully addressed. Now, why are we wasting our time talking about hypotension? Okay, now let us say we take cardiovascular death. And we take out those patients who entered paradigm with a blood pressure of less than 110. Borderline, right? Most of us would think, should we really start? Maybe we will wait. Maybe let him come back after follow-up. Maybe we will defer for some time. If he gets hypotension, what will I do? But it is this group of patients which showed significant benefit, golden bar in sacubital valsartan, with a relative risk reduction of 16%. So it is this patient who is going to benefit. So in our concern, in our fear, in our anxiety, that patient has baseline blood pressure of less than 110, should be start or should not be start. If we don't start, we are missing the bus. Today, any systolic blood pressure above 90, we have given sacubital valsartan, and carefully monitoring and titrating, we are able to maintain in most patients. Now let us look at heart failure hospitalization. Same story, right? Less than 110 BP, we have significant 9% reduction of heart failure hospitalization. So events do become lesser. So benefit is there in every subgroup. Simply because your baseline blood pressure is less than 110 does not mean we will not start on sacubital valsartan. So tips should be there. Tips for starting would be wait till inotropes are off. Yes. Reduce loop diuretic dose to the minimum, which gives him decongested, because more you diurese, ARNI-induced hypotension is going to be more. And of course, you have SGLT on board. If you have, this always takes out the volume. Necessary oral hydration so that you can avoid hypotension. Stop unnecessary vasodilators. A lot of patients might be on oral nitrate. Think about it. Does this patient really need a vasodilator? Reduce or stop unnecessary antihypertensives. Patient might be on an CCB, patient might be on alpha blocker for his prostate and might develop hypotension. If essential, absolutely essential, stop on it temporarily. But do restart. And many often you would see that next stage, as you restart, they tolerate it well. But whatever you do, our endeavor should be that in most patients, you try to put them on ARNI pre-discharge, if possible, right? If possible. The second interesting aspect that we would discuss would be the ideal dose level, right? Dose level. What is the impact of the low dose ARNI? Because, okay, we read trials, we read paradigm. The dose was 200 milligrams BID. Now, let us be honest to each other. How many of our patients actually tolerate and go home on 200 BID? So suppose these are 100 or maybe even 50 BID. Are we really doing a good? Or is it just that we are writing and there is no good for the patient? Let us check that out. Now, this data of paradigm HF again looked at the target doses in heart failure, right? And what was the effect? If you look at that and look at the reasons for dose reduction, why patients had dose reduction, you see the major cause was hypotension. 20% patients, both are. In Enalapril 16, sacubital valsartan 21% had hypotension. But look at the data, in about 36%, they could re-up-titrate the drug. So 1/3 of them again would tolerate and you could re-up-titrate, but some would not and would end up in low dosage. Now, if you look at the cardiovascular death and heart failure hospitalization, the primary endpoint, and you see obviously, people who received the full dose did the best. Their survival is better, right? But any dose reduction, you have a higher graph, which means it is not optimal. So obviously, we should try to give our patients the best trial-directed possible dose. But wait a minute. This very discussion went far beyond paradigm. And people said that, see, in reduced ejection fraction, many patients don't tolerate top of the line dosage. And what happens to them? And this data comes from about 835 patient data in real life, where this data came in JACC 2022, just last year, dose response to sacubital valsartan. Very interesting data. So this is basically real life data, where they looked into patients who received 3 different dosage of sacubitril valsartan. Look at that, 3 different doses. One was 112 milligrams. Second was 340 milligrams. And the last was 380, almost 400 milligrams full dosage. Why they received different dosage? Because they didn't tolerate. So these were, as per the physician's choice, maximum tolerated dose. Now this 3 dose, 100, 350 and 400, they looked at the left atrial volume index. So how big is the left atrium, right? You see that the reduction of left atrial volume index, 20% in all the groups. Surprisingly. Then they looked at the left ventricular end systolic volume index, 25% reduction in all the groups. Then they looked into the left ventricular ejection fraction improvement, 31% in all the groups, roughly matching 33 in the 380 milligrams group. NT-proBNP, roughly 40% reduction in all the groups. So we are not talking about rehospitalization or death here. If you look at the surrogates, the hemodynamics, the NT-proBNP biomarkers, the improvement is almost similar across groups. So yes, even 110 milligrams group benefited. Not just that, similar improvement in health status across all categories. So yeah, patient will come back and tell you, sir, I'm feeling well. And all his parameters are good. Right. So yes, there is improvement even when we use a smaller dose. A very surprising but a very small data came from this 200 patient data from South Korea. But this is about, surprisingly, a very low dose of sacubitril valsartan, 25 milligrams twice a day. Obviously something that we don't even expect to work. But these are the patients who did not tolerate anything more than that. And all of us know that there are patients like that, right? There are patients where they don't tolerate anything above 25. You go to next dose of 50, they develop hypotension or electrolyte disturbances, they don't tolerate, right? Now, this is what happened. These are patients who were followed up for 1 year, but a small group, as you can see, 205 patients. Cardiovascular death and heart failure rehospitalized on the left, heart failure rehospitalized on the right. Look at that data. Blue line, standard dose, red line, very low dose, no difference at all. The p-values are same. See, this is a very small group. And this does not indicate that you give a low dose. These are patients who did not tolerate a higher dosage. But when you take, compared to a standard dose, they still benefited. So the point is, go to a dosage range as directed by the trials. But even if your patient does not tolerate, whatever dose he is tolerating, you are doing him good. Even an ultra small dose of 25 milligrams BID might do him good. From that, so the tips would be try to be the full dose, but even a small dose is better than no dose, right? No dose. So that brings us to the next point of HFpEF. Today, with a huge amount of data of SGLT inhibitors in HFpEF, ARNI tends to have gone on the back seat. Yes, we know. That is because when we look at the Paragon heart failure trial that came in 2019, 4,822 patients, ejection fraction more than 45%, elevated NT-proBNP. They were given standard treatment versus standard treatment plus ARNI. What happened? We know that whether we looked at total hospitalization for heart failure or cardiovascular death combination, or just about total hospitalization for heart failure, there was no difference. Despite the fact that sacubitril valsartan line in red was slightly better, looked on the graph, there was no statistically significant difference, right? So it was kind of a failure. So when we look at HFpEF, this is HFpEF, and when we look into all these subsets, again, very clearly there was no benefit in any of these subsets. So Paragon HF showed that in heart failure with preserved ejection fraction, ARNI did not work. Or did it? Hold for a moment. If you look into the data very carefully, on the left you have valsartan, the dark blue graph, and sacubitril valsartan event rate on the right. Do you see a difference? Do you see a difference? Yes, 14.6 and 12.8. So the primary endpoint was just missed significance, right? So if you look at that endpoint, there was benefit, but if you look at that endpoint, the risk ratio was 0.87, 13% risk reduction. But look at the confidence interval. We want the confidence interval to be less than 1, right? Here it is 0.753 to 1.005. Just cross to the other side. Maybe one less event or one more event on the other arm, you would have pushed to significance. And the p-value, 0.0585, just above 0.5, right? So a very fragile trial indeed, very fragile trial. The fragility index would be very borderline, but certainly it is just a fence sitter. So maybe a couple of events this side and that side, we would have benefited. Keep that in mind when you think about ARNI and HFpEF. But then something very unique came, and that was in HFpEF, people looked at this time at which they had their prior hospitalization. Understand that these are post-hoc subset analysis, and we should take it very carefully before interpreting properly. But this data is very, very clear. If we take out those who had a heart failure in the past 30 days, we are talking about HFpEF hospital admission, they clearly benefited. The 622 patients had a confidence interval which doesn't touch unity. But when you look at the rest of it, there was no significant benefit. So HFpEF patients, if you start ARNI, within 30 days of hospital admission, they tend to benefit. Why? Because we should keep that in our mind. So such a subset, he might benefit with ARNI instead of an ACE inhibitor. The recent data also looked at something very unusual. They looked at the data on women, right? And what did they find? Something very, very unusual. Look at that data, right? If you look at the primary composite outcome in women, that means heart failure, hospitalization, death, you see that the benefit goes up to beyond 65 ejection fraction. Look at the right end of the box. The green line crosses the horizontal line where the benefit ends at beyond the ejection fraction of 65. Look at total hospitalization, the graph below, same data. So whether you are looking at hospitalization alone or hospitalization plus mortality, women tend to benefit even up to an ejection fraction of roughly 67%. What about men? What about men? Nothing like that. Total hospitalization for men, no benefit. So here we clearly see a gender difference. And how that translate? Is there a difference between neurohormonal sympathetic activation? We really, really don't know. But the data looks very interesting there. It tends to work in women, but not in men. Right. And that brings us to the last point of hyperkalemia. We know that hyperkalemia again, if we use ARNI instead of enalapril, hyperkalemia tends to be lesser. Right. We know that whenever you use a RAS inhibitor, there will be hyperkalemia. You need to be careful. But when we take potassium cutoff as more than 5.5, it is much lesser yellow graph of sacubitril valsartan compared to enalapril. What about if you put the potassium cutoff as 6, severe hyperkalemia? Again, the yellow graph of sacubitril valsartan is lower than enalapril maleate. What about discontinuation of MRA? See, today we want that all the 4 drugs, SGLT inhibitors, beta blockers, ARNI, and MRA should go in. So if there is hyperkalemia, the first thing we discontinue is MRA, right? Now, if you are using, for example, at 12 months, sacubitril valsartan in green instead of red in enalapril, you see the discontinuation of MRA is significantly lower. So one additional advantage of sacubitril valsartan instead of enalapril or ACE inhibitor would be that we might be better equipped in maintaining a stable MRA dose for our patient, giving him all the benefits of the 4 drugs together. We will just take 3 situations before we end this talk and take up questions. And one of them is sudden cardiac death, right? Sudden cardiac death. We know that sudden cardiac death is a big problem in heart failure, especially those who have class 2 heart failure, not much symptomatic, they suddenly die at home. Now, this is again John McMurray's data. He very elegantly showed that if you look at in this graph, x-axis is years, 95, 2000, 2005, 2011. And the y-axis, you have annual rates of sudden cardiac death. What do we find? We find that there's a progressive decline of sudden cardiac death over the years. Yeah, certainly because our drugs are becoming better, so the ventricle has a better geometry and we get a benefit. And the best of them is in paradigm HF with sacubital valsartan, where the sudden cardiac death seem to be lesser. So yeah, sacubital valsartan is a better drug from cardiac remodeling. So obviously we get lesser sudden cardiac death. Is that the only reason? Right. So this came very recently, very interesting article where on my mind is sacubital valsartan also an anti-arrhythmic drug, a very interesting write-up. Do read it, very, very interesting, where they've shown that, see, sacubital valsartan, right? They inhibit angiotensin, the neprilysin, and produce so many benefits, decrease myocyte death, decrease hypertrophy, fibrosis, inflammation, right? And they create what we call as reverse remodeling. And that is how sudden cardiac death comes down, right? We know that. And obviously, neprilysin is more powerful than valsartan alone. But we didn't know something else, and that is this. There's a huge unknown pathway of enkephalins, endorphins, and bradykinins, which go in a long way in creating arrhythmias. And is the antiarrhythmic effect because of neprilysin suppressing those huge amount of peptides that we showed you at the beginning? The answer is we don't know. But then when we look into this data of paradigm and sudden cardiac death, we see something fascinating. If we look into those who had a sudden cardiac death in ICD eligible patients without an ICD, and look at the non-ischemic cardiomyopathy, non-ischemic dilated cardiomyopathy, we see there is a significant benefit of prevention of sudden cardiac death by sacubital valsartan. And the hazard ratio is what? 0.71 and a tight confidence interval. So about 29% reduction of sudden cardiac death by sacubital valsartan. But when we look at the ischemic cardiomyopathy, the difference is not significant. So again, we see there's a stratification. So in non-ischemic dilated cardiomyopathy, ARNI is far better in preventing sudden cardiac death. The benefit seems not to be manifesting in ischemic dilated cardiomyopathy. Non-ischemic, yes, ischemic doesn't work that well in preventing sudden cardiac death. Point number 2, the question of ejection fraction agnostic, right? Today we talk about SGLT inhibitors. You don't need to even check ejection fraction. Heart failure, symptoms, elevated NT-proBNP, they will be good because they are effective in reduce the ejection fraction, preserve the ejection fraction. What about sacubital valsartan and ejection fraction, right? If you look into the data, you see, yes, the total cardiovascular and heart failure hospitalization. And on the x-axis, you have ejection fraction. Obviously, as the ejection fraction improves, the benefit decrease. Yes. But even then, if you take a cutoff at 65 ejection fraction, you see that equals to the baseline incidence of the hazard ratio of the standard controlled heart failure group who is not on sacubital valsartan, right? Which means that till about 62, 63, you still tend to have some amount of benefit with sacubital valsartan. That goes in line with what we saw in the Paragon HF trial of HFPEF, right? So what about combining all the data and trying to look into Paragon HF, which is ARNI, and Emperor Preserve, the SGLT inhibitor. We see the Paragon here is in blue, Emperor Preserve on red, and we very clearly see whether we are talking about cardiovascular death and heart failure hospitalization, whether we are talking about cardiovascular death alone, we see there's a very significant benefit with both, right? Despite change in ejection fraction, both the blue dot and the red dot are below the baseline, both cardiovascular death and death plus heart failure hospitalization. Once you cross that 62.5, the benefit of both of them, SGLT inhibitors and ARNI, tend to be lost, right? So both are effective in a broad range of ejection fraction. Every conference ends with asking that, do you have an Indian data? Well, the answer is no, but then yes, if you look into the Paradigm Heart Failure India sub-study, you clearly see that there were about 400 patients, there were about 468 patients in Paradigm, which we gave from India. And very clearly, whether you see primary composite endpoint, cardiovascular death, heart failure hospitalization, all-cause death, everywhere you see that it looks similar with the global data, and there is no difference in p-value. So there is no difference between the global data and the Indian subset, which means very clearly it also works for Indian race. And for example, we always say that some of the drugs don't work for Black population, but sacubitril/valsartan does have a benefit in the African Black population too. Okay, so the final thought is not regarding sacubitril/valsartan, but the data has come from Paradigm HF. What is it? It is about NYHA classification and outcome of heart failure. There's nothing to do with the topic we are talking about, nothing to do with ARNI or sacubitril/valsartan. But this data came very recently in December 2022, and I think it's important for all of us, right? Since Satish has given us a chance to share our thoughts, why not learn this before we end? In this huge data set, if you take those who are NYHA1, means no symptoms. So they have heart failure, but presently asymptomatic. 76% of them had an NT-proBNP biomarker more than 1,600. Normal NT-proBNP is 125, right? So we have a 76% of asymptomatic patients have a very high NT-proBNP. And these patients, when followed up in the Paradigm, had an extremely high risk of event rate. 3.4 times hazard ratio, right? 3.43. So what are we trying to tell you? When a patient sits opposite us or in the hospital bed, who is absolutely fine, no symptoms, does not mean that he has mild heart failure. There's nothing called mild heart failure, right? He might be having a very severely elevated NT-proBNP, and he might be at an extreme risk of rehospitalization, sudden cardiac death, or cardiac death, right? So there is no mild heart failure, even if he looks asymptomatic. So we end with this, where we say that simply because a patient looks happy and comfortable does not really mean that his heart is healthy, right? It does not really corroborate that he has a healthy heart. And so whether your patient is symptomatic or asymptomatic, go by the investigation reports, stratify his risk, and treat him properly. Today we have an array of drugs, ARNI, SGLT inhibitors, beta blockers, and MRA, which very clearly gives our patient a better survival. In a country where we have a 5-year mortality of 50% in heart failure, our endeavor should be maximally trying to give our patients the best possible combinations to give him a better outcome. Thank you for your time and attention. And if there are any questions, maybe you can put in the chat box so that we can try to answer.
Right, Doctor. This is Satish. Once again, Doctor, I believe because the platform is such that it would not come on the chat box, is what I understand. Though the slides were very lucid, new, a lot of new data shared by you. And I believe a lot of new things.
We can see a lot of questions here in the chat box.
So there are no questions as such now.
I can see here.
Except for one question is there, sir.
No, there are 4 questions. The question will come into the virtual platform. Okay, all doctors requested. Okay, right, I can see. I thought there are questions. Role of ARNI in right heart failure. Some queries you could address. Right, nothing much really.
Maybe, sir, if you could, still we have about approximately 10 minutes. Any take-home message, sir, for the clinicians? There are about 89 clinicians who are there live with us now. So any take-home message, because we'll not be able to get questions on the chat box.
I think certain things we should always address, that there are a lot of heart failures that are missed out, right? By missed out, we always normally address heart failure with preserved ejection fraction. We are not talking about HFpEF. HFpEF is often missed out. HFpEF would be a patient who comes with a good ejection fraction, but has features of effort intolerance or had a pulmonary edema and a very high NT-proBNP, right? If we check out his diastolic functions, they mostly might be abnormal. They have a left ventricular hypertrophy, large left atrium, the typical HFpEF. They might have a cardiac arrhythmia like an atrial fibrillation, background of diabetes or hypertension, stiff heart rates. We are not talking about that here. If we are talking about the pure heart failure with reduced ejection fraction, I think there's a significant proportion where we miss out. First would be asymptomatic left ventricular dysfunction. Right. The physician sends for an echo. The echo shows ejection fraction, let's say 45%. Patient, the doctor asks, how are you? Sir, I am fine. Do you have any breath? No, sir, I am doing everything normally. I am fine. I'm running around. I take my bike. I go to school, bring my children home. I am doing everything. I'm going to office. Simply because he has no symptom. This HFrEF patient still has a significantly elevated risk. And we need to treat him with all the possible drugs that we have that reduce cardiovascular mortality. So that is point number one. Asymptomatic HFrEF does not mean that he has a mild heart failure, number one, because the long-term trials have very clearly shown that this asymptomatic LV dysfunction, especially when they have an underlying diabetes, progressively worsen over time. If you look at the trajectory of ejection fraction, most of them over time would worsen, and this worsening needs to be prevented and addressed, number one. Second thing would be the heart failure that we miss out post bypass surgery, right? Many patients come after bypass surgery, see a VG, how are you? I am fine, thank you. Okay, you do an echo, you find some LV dysfunction. You try to tell him that there's an LV dysfunction, even he doesn't believe, right? He says, sir, I had bypass surgery. Because patients here believe that once they have a bypass surgery done, nothing really matters. All that he needs to eat is a statin and an aspirin, which has been told to him, forged in his mind by his surgeon. He need not take anything at all. But these patients with LV dysfunction, unless we address the issue of LV dysfunction, they're going to worsen over time and come back on some day with acute pulmonary edema. So I think these are certain subsets which we normally don't take care and miss out, and we should be careful in finding out and treating them with proper therapy.
So there is one question, if I understand, they would like to know regarding IRTI precipitating acute heart failure role of ARNI. I don't know that's relevant. That should be answered.
Can you tell me that again? What?
It talks. Would like to know regarding IRTI precipitating acute heart failure role of ARNI.
What is IRTI, by the way?
Yeah, I wouldn't know that, sir. I think one of them has put there.
Is it talking about a respiratory?
Or is it LRTI, sir, by any chance?
Oh, maybe that's it. Today we talk about, if we talk about infections, today we talk about a lot of patients. The trigger for worsening heart failure could be infection, either pneumonia or influenza, right? So we say that apart from the 4 drugs that we are talking about, couple of things we should take care. One is their iron status, and second, of course, they should be vaccinated against both influenza and pneumococcus. So these 2 vaccinations need to be taken because for a lot of patients, the precipitating factor, the trigger is an infection. Now, whether the trigger is an infection or ischemia, whether the trigger is an overexertion or mental stress or too much of salt or volume retention, doesn't really matter. They need to be treated with all the 4 life scale altering measures that we said, like SGLT inhibitors, ARNI, beta blockers, and MRI.
Right, doctor. So I believe it's 5 minutes to 8. We don't have any more questions, but I believe session was, as always, extremely informative, new content point of view, new take-home message, and I'm sure a new learning for a lot many clinicians who have attended today, sir. So I'm happy that at this point of time, we had about 80 plus clinicians who were live with us. And I believe this could be a good take home for a lot of the clinicians now, sir.
Thank you. Thank you so much for arranging this because I
So
suppose
there is one Dr. Ramaswamy, I think he wants to ask some question.
Sure,
He's
sure.
there online. Dr. Ramaswamy, you wanted to ask something? Dr. Ramaswamy?
No, Dr. Allegation is the next session speaker.
Okay.
Right.
Thank you, sir.
Okay,
Thank you very much.
bye. Thank you.
Thank you.
Good evening, Dr. Allegation, sir. Dr. Chandrasekharan, sir. So we can start off with your session, sir.
Okay, I think I'm going to go first, and Dr. Allegation is going to follow me later because I had to leave for the airport soon. Is it all right?
Yes, sir. Yes, sir. Absolutely.
Okay. So I think let me share the shared screen, right? First,
Yes, sir. You can share the screen.
let me go on to the. What is okay? Share screen. Okay. Screen and. Okay, very good. Share.
Is your presentation open, sir?
Yeah. It is. It's open. I'll open it up now. Can you see it?
Yes.
Okay.
No problem.
Okay. So I think I'm going to take off my this thing though with the what do you call it? No, it's all right. Okay. I think good evening, ladies and gentlemen. I think in the next 20 minutes, I'm just going to talk about the role of imaging in heart failure, especially with preserved ejection fraction. I think the basis of heart failure is, I think I enjoyed the talk by Dr. Nair earlier. I think it is the myocardial dysfunction, whichever way it can occur. It can occur as a result of pressure overload, or it can occur as a result of ischemia, or it can as a result of myocardial disarray. Whichever way it can occur, it is the dysfunction that results in LV filling pressure going up and developing symptoms of heart failure. But sometimes people do have the dysfunctional myocardium, but they don't have any symptoms. That's a preclinical stage, a subclinical stage. Imaging identifies these subclinical stages very nicely because you use an echocardiogram, it will be able to show you whether the muscle is contracting or not. And also it can tell you what is the reason for the muscle not contracting if you use the myocardial mechanics. So in this way, imaging plays a major role in identifying the patients with heart failure without having any symptoms so that you can prevent overt heart failure if you can mitigate earlier. What's the pathology and pathophysiology of heart failure with preserved ejection fraction? Where the imaging is going to guide us. The bottom line problem with the heart failure with preserved ejection fraction is the ventricular size is normal. That's the reason in 2007, European Heart had an end diastolic volume index for the body surface should be less than 100 ml. So the LV size should be normal and patient will have dysfunction of the myocardium, which can be either normal size or increased thickness, or it may not be, it may have some infiltration. Doesn't matter. The volume never increases and the function, systolic function is always preserved. So the imaging always identifies you which heart is having a normal volume and normal ejection fraction, so that in heart failure patients, one of the dictum what we need is to define whether they have preserved at reduced ejection fraction, and the cutoff was given as 50%. But the problem with heart failure is, it is, especially heart failure with preserved ejection fraction is, it is a combination of several comorbidities that we live with. Number one is aging. Number two is sedentary lifestyle. Number three is obesity, hypertension, renal disease, anemia. So many things are small things that add. The common linking factor for all these things is the endothelial dysfunction. So these things can precipitate. You don't have to have only one, not only uncontrolled hypertension or diabetes. You can have mildly controlled hypertension or mild borderline diabetes, mild renal insufficiency, on top of it, obstructive sleep apnea. All of them can put together and result in heart failure symptoms, where majority of them will have a normal ejection fraction. And as Dr. Nair pointed out, the female sex, where it differs, there the hormonal changes probably does something to the myocardial relaxation, and that could be adding on top of it. Same time, one has to be, so the imaging also plays a major role in identifying the masqueraders, the things that mimic like heart failure with preserved ejection fraction. All of you had had a patient would have come with shortness of breath. Suddenly, I've been feeling very well, sir. Now I have shortness of breath, and only when walking, it has gotten worse over the last few days. And you do imaging, and you'll find out that he may have a flail mitral valve. You may find it, the patient may have a tight aortic stenosis, or a patient might have gone into arrhythmia, or he may have constrictive pericarditis. So these are all the masqueraders where it is not heart failure with preserved ejection fraction. It is heart failure that has occurred due to structural valvular disease in a patient with a normal ejection fraction. Similarly, one also have to be careful that heart failure symptom can be brought on by coronary ischemia. You may have a normal LV function, and when you're walking, you have supply-demand ischemia, and you develop a shortness of breath, and you go to the doctor. At that time, you're not walking, you're sitting there, and he examines you, everything is fine, and he does the echo also, the resting stage, and every LV function looks normal, LVH. He says that you have heart failure with preserved ejection fraction. But on the contrary, you don't have heart failure with preserved ejection fraction. What you have is coronary artery disease. So here is a patient. So one of the first dictum is ejection fraction, which Dr. Allegation is going to talk to you nicely in detail. I'm just showing you for the sake of EF. This EF is less than 25%. It makes it much easier for us to decide, well, this patient is a low ejection fraction, so you got to do a lot of things in order to treat him. Because we have a lot of drugs, which Dr. Nair pointed out quite nicely. But on the other hand, here is a patient who also presents with shortness of breath in this case, but normal LV function. And RV is borderline enlarged, both ATR enlarged. But he presents with shortness of breath now, but on the other hand, he never had any symptoms in the past 2-3 years. So totally. So this is a patient where LV systolic function is preserved, LV is not dilated, and this fits in the diagnostic characteristic of heart failure with preserved ejection fraction. When you talk about heart failure with preserved ejection fraction, the imaging, one of the criteria what we expect to see is the EF. We can obtain the EF either by M mode or by 2D or by 3D or using multiple planes. Since the crux of the matter lies in the ejection fraction, eyeballing is a no-no. You can never, I can think that my eyeball is pretty good, but you verify it with several cases before, and M mode is no-no because you're also going to see only a high-speed view. So using multiple different views and tracing the endocardium and borders and getting the volumetric EF will be more reliable. So, and getting this volume, biplane volume, will add a little bit more than just a four-chamber volume, even though patient may not have wall motion abnormality. Okay, so this is important. And in here, the people recommend 3D volume. I do understand the limitations of 3D volume in getting in a person who's obese and all, but nevertheless, unless you practice, you're not going to get it. So when you do a 3D volume, you can nicely see the end diastolic, end systolic volume and all segment contractility, and this is a much more reliable. I'm keeping on coming back to volume. So this is where the data comes from. European Heart Journal Dr. McMurray, all patients with preserved ejection fraction had end-diastolic volume less than 100 ml. So getting a volume is critical. Now, this is a patient who has wall motion now, okay? But when the patient came in the echo lab, initially, she didn't have any. Patient was referred for heart failure with preserved ejection fraction with shortness of breath. At that time, LVH, hypertension, and when the patient was made to walk up one flight of staircase and come back, that wall motion developed. So this clearly points out to you that basically you have to exclude the supply-demand mechanism that can play a role when the patient is active, that can also elevate a filling pressure in order to cause a symptom. Now, this is another patient where shortness of breath and he's been doing very well, but as you know very well, as you can see very well, the value of echo is not heart failure. The patient does have aortic stenosis, mitral annular degeneration, so significant aortic gradient. So echo allows you. Similarly, this is another patient with a severe acute heart failure symptoms, and you look at this. So this is where it helps you. Now, identifying the structural abnormalities, either present or not, LVH, small ventricle, and then making sure that the contractility is okay, no other valvular disease that can be contributing. So echo plays a major role in identifying the structural. Now, with the functional, with the Doppler, we're able to assess the functional status of the ventricle. In a normal person, or in a patient who comes in at a resting stage, his hemodynamics may be normal. But when you disturb the hemodynamics, either by exercise or by doing some maneuvers, then you change the supply-demand mismatch, or you may change the afterload mismatch, then patient may start developing symptoms. Here is a patient, anything what we do, either hypertension or ischemia, whatever we do at the base, at the cellular level, it is the mismatch between the supply and demand. That's the reason the LV becomes stiffer, and not to accommodate the same volume, the pressure goes up. This is a fundamental principle on which we use the Doppler echocardiography. Here is a patient in the control stage. You use the mitral Doppler for the LV, which shows E wave and A wave. In a normal person, we know the E wave is about 0.8 to 1 centimeter, 1.2 centimeter per second. We also know that the deceleration time should be greater than 130 to 140 milliseconds, and EA ratio should be greater than probably 1.5 to less than 2. It should be. So we can also measure the isovolumic relaxation time from the closure of the aortic valve to the opening of the mitral valve, and the deceleration time. If you look at here is the LA pressure, this is the LV pressure. When the patient becomes ischemic by pedaling the bicycle, look at the A wave, starts going up, and look at where it crosses. And at the same time, look at the LV pressure also, its relaxation is tau is also prolonged. And now look at the LA mean pressure, closer from 20 to 22. This subtle thing, what we see, and look at the mitral Doppler, E wave has gone up, and the deceleration is slightly shorter, but if you waited longer, it might have come down. But look at the A wave. Here, the heart rate has also gone up slightly, and that could account for increase in the A wave. But certainly the amount of A wave, the taller A wave shows that the ventricle is stiffer. So you can get the ventricular relaxation capacity as well as the ventricular capacity stiffness using the E and A waves. And the hallmark of heart failure with preserved ejection fraction is, in a fully advanced stage, is the normal ventricle, dilated atrium, because the atrium is feeling the afterload here. LV is thicker and is not able to relax quickly. The pressure cannot be equalized quickly. So it takes a longer time. That's the reason LA becomes larger. And LA volume measurement is critical. Another factor, imaging for heart failure with preserved ejection fraction, is crucial, because I'll tell you why the LV volume, LVEF, and LV mass, and now the LA volume, all these structural parameters becomes important because the current European Heart Failure Association has come out with a guideline algorithm where they use all these parameters and they give a score to develop a score for heart failure with preserved ejection fraction. So you need to use the biplane volume and the area and the time, you can get the volume. This is a very old study done by Dr. Seward and Dr. Teresa Sang from our institution, clearly shows the value of LA volume in predicting who's going to develop cardiac heart failure. This is in the Olmsted County. So if the LA volume is larger, not only it affects the survival, it also tells you who's going to develop heart failure symptoms. So measuring the LA volume is as important as measuring your EF. So now coming to the Doppler itself, here is the mitral Doppler. The parameters that what we use to assess the diastolic function are one, mitral Doppler, the other one is pulmonary vein Doppler. Then the most important parameter that we use is how quickly the ventricular myocardium can relax. In other words, after it is contracted, if it is able to relax quickly, get rid of the calcium and all, is it getting the energy? So it's going to bounce back to where it was. That is shown by the tissue Doppler at the mitral annulus. So if this is robust, greater than 8 to 10, then you can close your eyes and clearly say the patient does not have myocardial dysfunction, no LV diastolic dysfunction, provided the pericardium is normal. Okay, so these parameters are used and we get the E and the E prime ratio between the E wave and the E prime. As the myocardium is becoming diseased, it is not able to relax, so the E prime comes down. As the E prime comes down, as the diseased myocardium doesn't allow the blood to flow in that quickly, so the LA volume, reservoir volume increases and LA pressure increases, so the E wave also becomes taller and the deceleration becomes shorter and the EA reversal becomes more than 2. So this is the pathophysiology. When one goes down, the other goes up. This is what will be used in E prime ratio. At the same time, pulmonary vein Doppler also gives us a clue. Normally, when the ventricle is contracting, atrium is actively relaxing. Then the ventricle is open, atrial flow occurs passively from the pulmonary vein into the left atrium into the LV. So the dominant flow that's occurring in pulmonary vein is active relaxation of the left atrium. So even in a very early stages, because its left atrium is constantly feeling the pressure of the LV, you will start developing left atrial stiffness. So the systolic wave may be becoming less and the diastolic wave may be becoming more. But obviously, when you look at it, it may not look this normal, but it may come down, it may still look normal. So in that situation, you also have to look at the atrial reversal. Is it thin or large? And how does it compare with the mitral A wave? So these are the various parameters what we use to calculate. So one of the examples here is, look at the normal E wave, A wave, normal E prime, A prime, and if you look at it, E prime ratio is 11. Whereas another patient, this has gone up, and A wave is very little, and E prime hardly you can see. So this is 60. So clearly you know that using these parameters, you can guess or you can come to a reasonable conclusion whether your patient's symptoms are due to elevated filling pressure and congestion. But here, look at this patient. Doesn't have any symptoms at all. LV, borderline LVH, RV is normal, LA is start becoming bigger, RA is bigger, LA is also bigger, but the pulmonary veins are dilated. Now, this patient is another patient where it's become thicker and annular calcification, and LA is not as big. Both of them, this patient has symptoms, the other patient doesn't have symptoms. So the patient who does not have any symptoms, if you look at the mitral Doppler, it is essentially normal. But when the patient is doing Valsalva, even though it looks normal, Valsalva reverses, okay? But your E prime is still 10, so E is still 8. But this reversal tells you that why should he have an enlarged left atrium? Why should it reverse? So it's a preclinical stage of diastolic dysfunction that's occurring when we're able to recognize. So we can say, yes, LV filling pressure is not normal, but on the other hand, this guy is eventually going to get to a level where this is going to be coming down and this is going to be gradually decreasing. So in this patient, whatever you can do, if he's got obstructive sleep apnea, treating that, or treating his hypertension aggressively, or treating whatever his other symptoms are, anemia, whatever it is, you may be able to prevent him getting into real heart failure. Now, this is a patient who has for looking at it casually, you look at the E and A prime, E and A wave, and you see the deceleration time. I think I need to take off my picture here for you guys to see the deceleration. It's about 120. 120 is a little shorter, but A wave is preserved. So EA ratio is about 1.2 or something like that. This is during inspiration. Now, during expiration, look at that. Deceleration time becomes 100. E wave becomes slightly bigger, not much. Very subtle change. Subtle change, but this patient is presenting with shortness of breath. And you do the cath, look at his LV EDP is around 22, but with expiration, it goes up to 35 to 40. So these subtle changes that Doppler can predict, based on that, you can optimize the patient management. Now, if you look at the atrial reversal, deceleration time and pulmonary pressure in the left atrium, the deceleration time, when it's going to be less than 175, majority of them had LA pressure, mean LA pressure greater than 70. But when it's going to be less than 150, 100, all of them had much higher LA pressure. So there is a reasonable correlation. Now, how do we use this evidence of diastolic function in our day-to-day practice? If the EF is greater than 50, if the end diastolic volume is less than 97 ml per meter square, and the E prime ratio is greater than 15, and if the patient has the risk factors that I pointed out, obesity, hypertension, female age, advanced age, and renal failure, any of these risk factors are there, automatically the current guidelines recommended by the EHA says that patient has got heart failure with normal ejection fraction. So they will have an enlarged left atrium. They'll also have an increased LV mass, which goes along with it. On the other hand, in this patient, and they also use the NT-proBNP biomarker. If it is going to be greater than 200 or BNP greater than 200, E is greater than 8. They expect here, when all these things are less, they expect E to be much greater. But on the other hand, only greater than 8. No, I think it is a mistake on the part of this thing. It should be less than 8. Then you need to consider heart failure with normal ejection fraction. On the other hand, if the BNP is greater than less than 200, then you need to use the A wave duration in the pulmonary vein and A wave duration in the mitral. If the pulmonary vein duration is longer by greater than 30 to 40 milliseconds, which has been shown by Dr. Hadley long time ago, then they have an increased LA pressure. Or if your LA volume index to body surface is greater than 40 ml, then they have heart failure with preserved ejection fraction. Or if the LV mass index is greater than 122 grams per meter square, or if the patient have atrial fibrillation. Atrial fibrillation by itself is a risk factor. When you see in a patient with symptom, they have LVH, normal LV function, and huffing and puffing, and they have that, and they have atrial fibrillation. Invariably, they're going to have other things also, but on the other hand, European Society considers it as a risk factor. Now, what is the role of exercise? Here is a patient, 63-year-old man. This is from Dr. J.O. 63-year-old woman with hypertrophic cardiomyopathy, recurrent pulmonary edema. So here you see the MR, and you look at that the resting stage, E and A is larger, E prime is 5. So E ratio is going to be only 12, okay, in this patient. Now, patient is exercising, MR definitely increases, but look at the E prime, E wave goes up. Look at the A wave, that also equally goes up. And look at the duration the A wave becomes. And stage 4, this becomes. So during the same stage, you can also measure the E prime. So normally in a normal person with exercise, your E velocity will go up, E prime will also go up. So E ratio will be normal. In a patient with heart failure with preserved ejection fraction, E will go up, E prime will remain exactly the same or decrease, the E ratio will go up. So this is one way one can use the exercise exercise study in order to identify those patients who have symptoms during exercise but not at rest. So the same patient, when she was in the cath lab, you can look at her, what the LV-EDP was, which was around 15 to 20, and while she's bicycling, going up to 40. So now we know that the diastolic function by echocardiography can assess even the dynamic changes that changes in the clinical situation can produce. So, ladies and gentlemen, the distinction between heart failure with preserved ejection fraction or reduced ejection fraction depends on so many things. It should include epidemiological differences, that is man, female, old, how old they are, less than 75, greater than 75, Afro-American, or what. Then morphological differences. LV wall is thicker or thinner, and what is the volume, and what is the characteristics of myocardium. And you also have to use your generally your strain. I didn't talk about strain rate. Strain will allow you to assess the myocardial pathology even before you can develop the symptom. So one can use strain. Similarly, LA strain is also becoming more important, that it can allow you to recognize early LA dysfunction before the Doppler can show. So these two things can be added, but they are not routinely used in the guidelines. They are not routinely recommended. So that's the reason I didn't talk about it. In general, patients who have got a heart failure with preserved ejection fraction, very rarely they go on to develop heart failure with reduced ejection fraction. In other words, the LV will never dilate. If it occurs, there is some other injury that has occurred. Most likely is MI. Otherwise, it won't. It will remain exactly the same. Preserved ejection fraction is always there until otherwise you aggressively control the risk factors that are associated with it. Thank you. Again.
Yes, I am there. If there are any questions to Dr. Chandrasekhar, they can ask. Otherwise, you can proceed, and I will share the screen and follow up with the lecture.
Thank you. Thank you again. Bye-bye. Thank you.
Bye. Is my screen visible?
Yes, sir.
Yes, okay. Shall I go ahead?
Yes, please.
My talk has been more simplified by the prior talk by Dr. Chandrasekhar about heart failure with preserved ejection fraction. So my talk will be on imaging in heart failure with reduced ejection fraction, especially with regard to diagnosis, prognosis, and follow-up. All of you know the definition of heart failure: the inability of the heart to pump blood forward at sufficient rate to meet the metabolic demands of the body. or the ability to do so only if the cardiac filling pressures are abnormally elevated. This should happen at rest and also during exercise. Even if during exercise, the pumping function comes down or the filling pressure is elevated, then they are having cardiac failure. Heart failure can present in different ways. It can present in acute heart failure or as a chronic heart failure. An acute heart failure can present as pulmonary edema. It can present with cardiogenic shock or acute decompensation of a chronic heart failure. The algorithm for the diagnosis of heart failure is simple. All of us know the symptoms of cardiac failure. We have to go through the symptoms of the patient, then do a proper physical examination and obtain an X-ray chest, PA view, and an ECG. From these information, most of the time we can say that this patient is having cardiac failure or this patient is not having cardiac failure. The next test which we do after, say, clinical history, physical examination, ECG, the next most important test, which is very useful for the diagnosis and also classification of heart failure, is echocardiogram. So echocardiography is the most important investigation, and in certain selected cases, patients can be subjected to other investigations like computer-assisted tomography or MRI or cardiac catheterization or PET scan. So these are the other imaging modalities which are useful in the, especially to find out the etiology of heart failure. If you see the heart failure, you can see this is the European Society guidelines on heart failure. Transthoracic echocardiogram is the most important investigation in the diagnosis of heart failure, chronic heart failure. The recommendation is 1C. And in patients with suspected acute heart failure and also in patients with cardiogenic shock, again, echocardiography is one of the most important investigation for the diagnosis. Echocardiography can rule out structural heart disease. So this, once you do the echocardiogram, immediately we know this patient is having a severe mitral stenosis with a large left atrial thrombus which is floating inside, and this patient has to go to the surgeon. This is another patient with the mitral valve disease. You can see a large perforation in the anterior mitral leaflet with aneurysm of the mitral leaflet, and there is a significant to and fro flow from the aneurysm into the left ventricle, producing cardiac failure and pulmonary hypertension. So immediately, the echocardiography can find out structural heart disease. When we come to myocardial heart disease, the most important thing is the ejection fraction. Dr. Chandrasekhar talked to you about ejection fraction. A mode echocardiogram should not be used for measuring the volumes. The two-dimensional echocardiography, especially the biplane Simpson method, is the method for measuring the left ventricular diastolic and systolic volume and calculate the ejection fraction. If your center is equipped with a three-dimensional echocardiogram, the three-dimensional echocardiographic volumes and the ejection fraction are the best. So either you should use the two-dimensional or a three-dimensional echocardiogram for measuring the volumes and the ejection fraction. The normal volumes are available. Say the ejection fraction is about 50 to 52% in a normal person, slightly higher in women. So we have to measure exactly the volumes and the ejection fraction. Apart from that, the LA volumes are also very important in heart failure. A LA volume of more than 34 ml per meter square indicates that the patient is going in for cardiac failure. So apart from these volumes, the diastolic parameters, this was discussed in detail by Dr. Chandrasekhar, how to classify the diastolic dysfunction into normal, type 1 diastolic dysfunction, type 2 or a pseudonormal pattern, and type 3 or restrictive pattern, and when to use this diastolic dysfunction for testing. Say when a patient comes to you, when you are seeing it is normal, but you suspect this patient may be having a diastolic heart failure, you subject them to a diastolic stress test or a systolic stress test. So which patient should be submitted for that was discussed by Dr. Chandra. And the most important another investigation which can tell you about the systolic and also diastolic function is the spectral tracking strain. This was not discussed in detail because it is an important part of the echocardiographic examination. Speckle tracking can detect subclinical LV dysfunction. Suppose in a patient who is undergoing cancer chemotherapy, even when the left ventricular volumes and the left ventricular ejection fraction is normal, when the speckle tracking strain goes down, it indicates that the patient is having a myocardial injury. So speckle tracking strain, apart from diagnosis, it can even in subclinical stage, it can predict that this patient is having myocardial injury and is going to develop dysfunction. So based on this systolic and diastolic function parameters, we divide the heart failure into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And there is another group which has been proposed by the European Society but not accepted by the American Society, a heart failure with mid-range ejection fraction. I will show you some cases where echocardiography plays an important part in the diagnosis and management of the patient. This is a patient with diabetes, smoker, hypertension who came with cardiac failure. And this is the echocardiogram. The echocardiogram immediately tells you that the patient has got a global hypokinetic contraction of the left ventricle with severe left ventricular dysfunction. And if you see the Doppler pattern, this patient has got a restrictive pattern with the pulmonary hypertension. You can see the tall E wave and a small E wave in the LAOT Doppler. This alone is enough to tell that the patient has got a restrictive pattern. And the other parameters also can be used for assessing the left ventricular end diastolic pressure, etc. And this patient underwent a coronary angiogram. There was a triple vessel disease. You can see the anterior descending artery and the circumflex artery are severely diseased. Like the usual Indian vessels, the vessels are very small and there is a severe stenosis. You can see the stenosis of the right coronary also. So this patient underwent a bypass surgery, Lima to LAD, Rima to LCX, and saphenous spine grafts to PDA and PLB. And see the improvement. So after 3 to 6 months of after the surgery, and also appropriate guideline-directed therapy for heart failure, the left ventricular function has remarkably improved. If you see the mode echocardiogram also, you can see the mode echocardiogram, the mitral value, the EPSS has started decreasing and it is almost completely normal. The LA dimension has decreased and it is completely normal. And also the Doppler pattern. From the restrictive pattern, you can see the E wave become lesser and the A wave becoming more prominent. And after 6 months, almost they are equal. So the diastolic function has almost reversed. So the systolic and the diastolic function has reversed after a bypass surgery. This is another patient with anterior wall myocardial infarction. So the entire interventricular septum, left ventricular anterior wall, and the left ventricular apex are showing akinetic contraction. This patient has got an ejection fraction of only about 30%. The left atrium is also dilated. So this is a patient with myocardial infarction with reduced ejection fraction producing cardiac failure. So apart from the clinical features, the systolic function, if the ejection fraction is less than 30%, these patients are not, the mortality rate is going to increase. If they have additional diastolic dysfunction in the form of pseudonormal pattern or restrictive pattern, again, this is the prognosis is bad. If the E by E prime is more than 15, the prognosis is bad. So apart from the clinical features, the echocardiographic systolic diastolic function and E by E prime ratio gives you an idea about the prognosis also. Again, the left atrial volume index. Say if the left atrial volume index goes beyond 34 ml per meter square, the prognosis starts decreasing. So they have the mortality is higher and it's related to the LV volume index. So echocardiographic not only can diagnose and also it can guide you in the follow-up, and also it can give you information about the prognosis. This is another patient who presented with VT, ventricular tachycardia, promptly cardioverted, and this was a patient again 60 years with diabetes. This patient, they thought that the patient may be having coronary artery disease, so they went ahead and did a coronary angiogram. So this is the X-ray chest, and this is the echocardiogram. You can immediately tell that the ejection fraction is markedly diminished, the left ventricle is dilated, and the ejection fraction will be only in the range of 25 to 30%. The left atrium is also markedly systolic and diastolic dysfunction. You can again see the restrictive pattern in this patient. After treatment, he was taken up for cardiac coronary angio. You can see. What is this? This is an Alcapa, anomalous origin of blood coronary artery from the pulmonary artery. You can see the blood flow from the right coronary artery traveling through the intervertebral collaterals into the left coronary artery, and the left coronary artery is arising from the pulmonary artery. So this was a surprise. So this patient was not willing for surgery, and he was continuing the medical treatment. When we did the echocardiogram, we missed this right coronary dilatation. The right coronary was markedly dilated. The left coronary origin was not clearly visible, but still we were not able to clearly make out the left coronary origin from the pulmonary artery, even after the diagnosis was made from the angiogram. There are other cardiomyopathies which are reversible, so muscle injuries which are reversible. One of the common one is the myocarditis. So this was a lady who presented with severe left ventricular dysfunction with thrombus inside the left ventricle. In this patient, we started the guideline-directed medical treatment. You can see the thrombus has completely disappeared after 2 months of guideline-directed medical treatment and also anticoagulation. And after 6 months, you can see the left ventricular function has almost completely become normal. So similarly, in the say echocardiogram, again, you can see this is 1 month, there is some improvement in that. So 6 months, there is a complete restoration of the left ventricular systolic and the diastolic function. This is again the diastolic parameters which are becoming normal after treatment. In these patients, MRI is also useful. Say an MRI can distinguish between say cardiomyopathy, which is congenital or due to genetic causes, and myocarditis. In myocarditis, we get gadolinium enhancement in the mid-myocardium in patchy areas. This patient showed a reduced ejection fraction, dilated left ventricle, but there was no enhancement of the left ventricle at all. So there was no scar in the left ventricular myocardium. When there is no scar in the left ventricular myocardium, that is a good sign. That is a sign which will tell you that if you treat them properly, there is an evidence that there will be positive remodeling and the ejection fraction will improve. And as shown in this patient where there is no scar, the ejection fraction has become almost completely normal. The diastolic dysfunction also has become, diastolic function also completely normal. One of the other cardiomyopathies which can reverse is a peripartum cardiomyopathy. 80% of the people with peripartum cardiomyopathy, they recover their daily function, but 20% they recover partially, and we have seen deaths also in peripartum cardiomyopathy. This is one of the unfortunate patients who didn't improve with medical treatment, and after 3 to 6 months of guideline-directed medical treatment, the patient was continued to have left ventricular dilatation and severe left ventricular dysfunction. Takotsubo cardiomyopathy or a stress-induced cardiomyopathy, another condition where it is there is a akinetic contraction of the lower 2/3 of the left ventricle. So this is present in all the walls of the lower 2/3 of the left ventricle, irrespective of the blood supply of the whether it is in LAD territory or RCA territory or circumflexury. That is the one which distinguishes it from the coronary artery disease. When a patient develops myocardial infarction due to coronary artery disease, usually the wall motion abnormalities are restricted to the area of the coronary artery which is obstructed. Whereas in Takotsubo cardiomyopathy, it is not restricted to the area of the blood supply. It is present in the lower 2/3 of the intraventricular left ventricle. There are different types of Takotsubo cardiomyopathy, but this is the one which is classical, and the prognosis is usually good. They recover their function after treatment. Tachycardiomyopathy, that is tachycardia producing left ventricular dysfunction, is another condition which you have to remember. One of the important thing is incessant ventricular tachycardia, especially due to vesicular ventricular tachycardia, is one thing which can present as cardiomyopathy. This is another patient with actually left ventricular dysfunction due to atrial fibrillation and a fast heart rate. You can see this is a patient with atrial fibrillation, fast heart rate, left ventricular dysfunction, and there is significant mitral regurgitation. So in this patient, if you can control the ventricular rate itself, the function is likely to improve. If you can say do treatment for the atrial fibrillation and convert it into sinus rhythm, the improvement will be faster. So even controlling the heart rate is beneficial in this patient with atrial fibrillation and fast ventricular response. Why should we diagnose what the cause of the reduced ejection fraction? As I told you, certain type of reduced ejection fraction cardiomyopathies have better prognosis, whereas certain conditions have bad prognosis. Pericardial cardiomyopathy has got the best prognosis. The idiopathic or the genetic variety is the one which has the next best prognosis. Cardiomyopathy with ischemic heart disease is midway between all the other types, whereas cardiomyopathy due to cardiotoxicity drugs like doxorubicin and infiltrative cardiomyopathy like amyloidosis, etc., and cardiomyopathy due to HIV infection, they have a very bad prognosis. The cardiomyopathy can present as a mild form in the initial stages. This is actually a boy who presented to me first with genetic cardiomyopathy. At the time of presentation, it was 45, but within 2 to 3 years, the disease progressed and he passed away. That is the spectral tracking, which shows that the spectral tracking strain is -16, indicating good prognosis at that point of time. But this declined within 2 to 3 years and the patient passed away. Another patient with genetic cardiomyopathy, severe left ventricular dysfunction and cardiac failure. Echocardiographic ejection fraction was 28% in this patient, and you can see the diastolic function shows a restrictive pattern with an elevated left ventricular end diastolic pressure. This is another patient with actually a cardiotoxicity, lymphoma, who has undergone chemotherapy, and he was not followed up routinely with echocardiogram and spectral tracking strain, and he's ended up with an end stage severe left ventricular dysfunction, diastolic dysfunction, and significant mitral regurgitation. At this stage, usually it is going to be very difficult to reverse the damage. Whereas if you pick up these cases in the mild stage itself or before they become clinically important, then we can give guideline-directed medical treatment, or we can change the drug which is used for the malignancy treatment, and so the patient can benefit from the therapy. This is another patient with a Duchenne muscular dystrophy, which shows actually a prominent R wave in the V1, which is characteristic of Duchenne muscular dystrophy with ventricular involvement. That severe left ventricular dysfunction in a patient with Duchenne muscular dystrophy. There are rare cardiomyopathies like non-compaction cardiomyopathy. This is one of the severest case which I've seen. The entire left ventricle was non-compacted. There was involvement of the right ventricle also in this patient. There was a left ventricular non-compaction, right ventricular non-compaction, and these patients will need only, say, heart transplantation for survival. And this is another patient with non-compaction. You can clearly see the non-compacted area. And this patient again is having a severe left ventricular dysfunction. So in the short axis, you have to assess the non-compacted and the compacted area. The non-compacted to compacted area ratio should be more than 2:1 to call it as a non-compacted. If you have any doubt, you can use the this is contrast echo for visualizing the non-compacted area and the compacted area. We can use the contrast echo, or we can use the MRI. So there are criteria from the MRI which are helpful for the diagnosis of non-compaction in borderline cases of non-compaction. Right heart failure also can be produced by heart failure with reduced ejection fraction. This is a patient with dilated right ventricle, right atrium, who presented with ventricular tachycardia on reversion. This patient had thrombus inside the right ventricle. There were aneurysm formation in the right ventricle, and this was a patient with typical ARVD. Whenever you suspect an ARVD, we can go ahead and do a CT angio, and it can show the fatty infiltration of the right ventricular anterior wall. This is the fatty infiltration. The whitish shadow is the fatty infiltration which is present. And also it can show the aneurysm, and the thinned out right ventricular anterior wall can be picked up by the CT scan. So this is the fatty infiltration of the right ventricular anterior wall. This is the thin bulging right ventricular anterior wall. And this is the right ventricle, which is markedly dilated, almost the diameter is equal to that of the left ventricle. And we did a LV angio also, which showed the marked aneurysmal projections in the right ventricular anterior wall, which is characteristic of arrhythmogenic right ventricular dysplasia. Echo is also useful in finding out which patient with dilated cardiomyopathy will be useful to undergo CRT. This rotating type of motion, if it is present, usually these patients are benefited by CRT, or we can use the criteria of U criteria of from the tissue Doppler to find out which patient will benefit from CRT. Even though most of the electrophysiologists now believe that they don't believe in echocardiogram for predicting which patient will benefit from CRT. Heart failure also can occur in children, and this is one of the typical cases in a child about 3 months old presenting with severe acute heart failure. And you can see the glistening cardiac. Whenever you see a left ventricular dysfunction with a glistening cardiac and a significant mitral regurgitation, this is again anomalous origin of left coronary artery from the pulmonary artery. And this patient will benefit from surgery. So here you can see the origin of the left coronary artery from the pulmonary artery, and you can see the flow, reverse flow inside the pulmonary artery. So echocardiography plays a key role in patients with heart failure for the diagnosis, including etiology, prognostic stratification, also treatment planning and monitoring. Assessing cardiac structure and function allows a comprehensive evaluation of the patient's status for better decision making. Newer methods like strain-based imaging may further add to the echocardiographic armamentarium, providing incremental information for the prognosis and also follow-up of the conventional cases. The different modalities, the imaging modalities should be used as a complementary method for assessing the patients and finding out the etiology, and also for the better planning of the treatment for patients with heart failure with reduced ejection fraction. Thank you. Hello.
Thank you, sir.
Yeah.
There is one question, sir. I'll put it in the chat box.
Can you? I'll go through it otherwise. 1 minute. Chat box. Okay.
In obese and COPD patient to detect heart failure, which alternative window should be used?
Usually, not all obese patients will have a poor echo window. That thing should be taken off your mind. There are obese people who will have a good echocardiographic window, and thin people who will struggle with the echocardiogram. Okay, so in obese people, transthoracic echo is the one which is to be used. But say if the imaging is not good, then we have to take it at that level, at that face value, and go ahead and assess the patient. So that's the way we have to do. Say there is no special window in which the obese patient we can get a better image and all that. In patients with COPD, especially you can try a subcostal window. Apart from parasternal window, because the lung disease, the lung may be encroaching on the transthoracic parasternal window. So a subcostal window, if you can get a good image from the subcostal window, we can use that for the diagnosis and follow-up. Hello.
Thank you, sir.
Yes.
Yes, sir. Thank you. That is all questions were there, sir.
Yes. Okay.
Thank you very much for your time, sir.
Okay. Thank you, Dr. Woman, for asking us to present this web-based program on heart failure. Thank you very much. Thank you.